Alright, so after reviewing hypokalemia, here we have the opposite situation, which is hyperkalemia, or an excess of extracellular potassium that goes over 5.5 milliequivalents per liter. If you remember, there is an internal and external balance of potassium, here represented by the two dotted boxes. For the internal balance, remember that intracellular potassium accounts for 98% of the total body potassium. This is normally about 150 milliequivalents, whereas outside the cell it's only about 4.5 milliequivalents per liter. Also remember that potassium establishes an overall electrochemical gradient across the cell membrane, which is responsible for setting the resting membrane potential of excitable cell membranes. Also remember that this balance is maintained mainly by the sodium-potassium pump, which pumps two potassium ions in for every 3 sodium ions out. Regarding the external potassium balance, remember that we get between 50 milliequivalents to 150 milliequivalents per liter of potassium through the diet, so the excess has to be excreted by the kidneys. So given these two circuits, hyperkalemia can develop in two ways. The first is an external balance shift, which is most often caused by a decrease in sodium excretion in the kidneys, which raises the level of potassium in the blood. And the second is an internal balance shift, where potassium moves out the cells and into the interstitium and the blood. One potential cause of an internal potassium balance shift is insulin deficiency. All right. In the other case, hypokalemia could develop if you got a shot of an excess of insulin. But in this case, is the insulin deficiency, which is normal in diabetics. And this is because after a meal, glucose increases in blood, and at the same time, insulin gets released, which binds to cells and stimulates uptake of that glucose. But insulin also increases the activity of the sodium-potassium pump, which pulls potassium into the cells. People with type 1 diabetes don't make enough insulin, so when they eat a meal, especially a meal with a lot of potassium, that potassium sits in the blood instead of being taken into the cells, and this causes hyperkalemia. Another cause of an internal potassium balance shift could be an acidosis, which is when the blood becomes too acidic. In other words, there's a higher concentration of hydrogen ions, which means a lower blood pH. We will see that in the next video. One way the body can increase the blood pH is by moving hydrogen ions out of the blood and into the cells. So in order to help compensate for acidosis, hydrogen ions enter cells and potassium ions leave the cells and enter the blood, which might help with the acidosis, but it may also result in hyperkalemia. Now, this isn't always the case for acidosis though. In respiratory acidosis, potassium levels aren't affected because CO2 is lipid soluble and freely moves into the cells without being exchanged for potassium. Therefore, no hyperkalemia. We will see this also in the following lecture and video. Another important mechanism is hyperosmolarity, where the osmotic gradient pulls water out of the cells and into the extracellular space. Less water in the cells increases potassium's concentration gradient and pushes more of it out of the cell and into the blood and causes hyperkalemia. Cell lysis is yet another cause of hyperkalemia, since so much potassium is kept within the cells. When a large number of cells die or lyse, that's a break, potassium is released into the blood, which causes hyperkalemia. And examples of large-scale cell lysis are severe burns, breakdown of a skeletal muscle, or tumor lysis as a result of chemotherapy. A final example of internal potassium balance leading to hyperkalemia is exercise. During exercise, while the body cells are working harder, more cellular ATP gets consumed. The depletion of ATP triggers potassium channels on the membrane of the muscle cells to open up, which allows potassium to move down its electrochemical gradient and out of the cell. Usually this shift is small, but if combined with beta blockers, those are drugs for cardiac disorders or kidney issues, strenuous exercise can lead to hyperkalemia in those cases. All right. External potassium balance shift has to do with potassium intake and excretion. Taking in too much potassium can lead to hyperkalemia, and this typically happens in a rapid excessive infusion of potassium into the bloodstream, like in patients receiving intravenous fluids, and this would be considered iatrogenic, which means that is the result due to a medical procedure or a medical error. Most of the cases have to do with the kidney's ability to regulate what stays in the blood and what is excreted in the urine. Remember that potassium is freely filtered from the blood into the urine at the glomerulus, and that after initial reabsorption, about 13% of potassium can be regulated depending on what the body needs. Now, reabsorption in this area is taken care by the alpha intercalated cells, while secretion is controlled by the principal cells. All right, here they are represented, both of them, by only one cell, okay, performing the two actions. Typically, for people on a normal diet, most of the remaining potassium is secreted if it's not needed. And this is controlled by aldosterone, which can increase the number of sodium channels and the number of potassium channels on the lumen side, that's you see in the right side, as well as the sodium-potassium pumps on the basolateral side, you see it in the left, of those renal cells we mentioned and that you can see in the image. As you can see, in situations where somebody is unable to produce enough aldosterone, like in adrenal insufficiency, there is less potassium secretion by the renal cells, and therefore more potassium is retained, leading to hyperkalemia. Also, drugs that reduce the effects of aldosterone can also cause hyperkalemia. Remember from Human Structure and Function 2, the renin-angiotensin-aldosterone axis. Okay, so all the drugs used to control hypertension that act in that axis can cause hyperkalemia. Also, in the case of acute kidney injury, there is low glomerular filtration rate, which is the volume of blood filtered through the kidney, and this can lead to oliguria, which is less urine, and hyperkalemia due to a defect in the elimination of the excess of potassium. All right, so there are all these ways to develop hyperkalemia, but what happens when somebody has hyperkalemia? Well, remember that the concentrations of potassium inside and outside the cells was super important for maintaining the resting cell membrane potential, and this allows a cell to depolarize and a muscle to contract, whether it's a skeletal, smooth, or cardiac muscle. So with too much potassium outside the cell, the membrane potential can become more positive to the point of even causing contraction. Initially, this might cause mild intestinal cramping when affecting the smooth muscle, but eventually the resting membrane potential gets so high that it's above the threshold potential, meaning that once the muscle depolarizes and contracts, it can't repolarize to another contraction. In skeletal muscles, this can cause weakness and flaccid paralysis that starts in the lower extremities and ascends upward. Hyperkalemia, though, also will affect the cardiac muscle, and this is what is dangerous about, which in this case can lead to cardiac arrhythmias and cardiac arrest, and death. Hyperkalemia is diagnosed based on the presence of an elevated potassium level in the blood. Okay, it's more than 5.5 milliequivalents per liter. It's also important to get an electrocardiogram, which typically shows a peaked T wave. Now in this drawing, I forgot in the last one, but in this image I named the different waves, so you have some idea, although we will go through all these in the heart lecture. Okay, so peaked T wave, a shortened QT interval that you have drawn here with a dotted line, the QT, and an ST segment depression. All right, so it won't be a normal electrocardiogram. Severe hyperkalemia is life-threatening. Okay, have this very clear. So the target is to reduce blood potassium levels immediately by pushing it into the cells with the help of insulin, glucose, and sodium bicarbonate, as well as using potassium wasting diuretics to promote potassium elimination in the kidneys. And in severe cases, you can even decide to do dialysis. So in dialysis, the blood goes through a machine that may clean up very efficiently potassium. All right, and this is all for hyperkalemia, a very important subject. Coming next, pH balance, which is also very important. See you there.